Thank you. So this title, Hybrid Management of Hamilton Entrapment Syndrome. So here okay. I think that this title must be more important to the vascular surgeon. However, let me start with the case series. This is a 66-year-old man. This should be, very important both for interventionist and the surgeon. So this 66-year-old male patient is a focal, relatively younger patient and the relatively less risk factors. And this focal tight region near the pamnutial or the rear P1 to 3 segment of distal involving distal SFA, we always should think of this is real ASO or really external compression. So when we consider this kind of this profuse adjacent collateral to the distal circulation, patients are not coming with the wound. Many are coming from the claudication. In the case, we have to think of this must be chronic processing and should look at this cross-sectional image from both CT angiography or the MRI, and should carefully check the cross-sectional image whether there is something external compression or not. So this particular case, there must be, this patient included this cystic component. So this cystic mass was compressed in the pamnutial artery. So multiloculated cyst lesions were found in the knee joint MRI. So this patient underwent the surgical. I sent to the vascular surgeon, and this patient underwent surgery, and the post-op ABI was increased. However, this patient, after 3 months later, followed up both surgical department and the intervention department. A patient felt claudication again. So we did the follow-up CT angiography, and we found that there's another region here. So disease progression was found. So did an additional angiography, and the symptom was relieved and the ABI was increased. So this kind of situation, not only the external compression, but also patient always can have the de novo progression of disease. So this kind of a sequential hybrid management was required in this particular patient. Case 2, this is a patient that sudden onset of occlusion, sudden onset of claudication, 32 years old male, very younger patients. This patient, due to urgent pain, however, some collateral was developed, and the B collateral to the distal circulation, and the hazy on both CT and the angiography, hazy thrombotic material was found. So I decided to do the thrombotic component management by the angiogen process. So the TPA, the infiltration, and by the protocol, thrombosuction was done mechanically, and just one thrombosuction, the nice result was achieved. Then just additional balloon angioplasty and focal thrombosuction by the catheter embolectomy, without aggressive management, just a good result was achieved. So after this younger patient, I usually do this kind of test before just the angiography before after dorsiflexion, after plantar flexion. So plantar flexion, it was okay, but the dorsiflexion, it was occluded. So functionally, it means that something, there must be external compression. So you have to think of there must be something trouble in the outside of the pulmonary artery. So when I look at this CT angio retrospect in cross-section, there is a gastrocnemius head was compressed in the pulmonary artery. So this should be surgically removed. So after taking additional MRI finding, we decide to do the surgery. The medial head of gastrocnemius relief. So pulmonary artery entrapment syndrome definitely requires the surgery. There's a type 1 to 4. So this need different among the different type. We need to the surgical resection of this medial head and release of the pulmonary artery. So after the surgical correction, this patient relieved from this pulmonary entrapment syndrome. So non-atherosclerotic pulmonary disease, PAES and the cystic adventitia disease is the most common, and especially young age with less ASO risk factors, we always should think of before giving injury in the pulmonary artery by the aggressive balloon or the stenting, you have to think of we should send the patient to the surgery or not. So this PAES etiology, median age is very young, and bilateral symptoms is less than 30%, less than 50%. So should think over this epidemiology. This is embryo development variation, and there is 4 different classification. And symptom, we have classification from 0 to 5 up to the asymptomatic to the necrosis. And this is good manageable. You can take the angiography during angiography test, whether the good image can be disappeared during passive dorsiflexion or active plantar flexion. So this kind of physical maneuver after angioplasty, you have to check the CT cross-section image and the MRI finding, then should identify the external compression, then decide the surgery. And after that, then this operation and we have to before operation or after operation, many cases we need a hybrid management because this particular case also needed the endovascular management before sending to surgery. So after surgery, patient also can recover due to the underlying. Always that is not clean by the surgery. After surgery, they can be also recovered by the proximal distal disease. These patients also had BTK disease. So after surgery, a few weeks later, I did the BTK angioplasty together. So always we need hybrid management. Even patients had the external compression disease in the pulmonary external compression. Thank you for your attention.
We'll all have the questions in the end. We also have your second talk on endovascular management of popliteal CTO. This would be a very interesting session because we are talking about popliteal CTOs, entrapment syndromes, occlusions, and also restenosis. So we will have a real good discussion on this after we have your talk and Dr. Busquet's talk, and also aneurysms.